So,
Thank you for nice introduction. Good afternoon, dear colleagues, dear panel members. It is really great pleasure to be part of this session. My name is Ekaterina Laukhtina, and today I will present a case on the topic how to improve conventional cystoscopy for bladder cancer in diagnosis and follow-up settings. I have no potential conflict of interest to report. And let me introduce our patient. For the case of today, it is 82 years old gentleman. He came to the office with gross hematuria. He is former heavy smoker. Among comorbidities, he has diabetes and hypertension status, and he does not have previous history of bladder cancer. And I would like to start with brief questions, brief discussion during case presentation. And first question I would like to address to Álvarez-Maestro, a professor. Do you perform biomarkers testing in addition to histology at the diagnosis setting? And if yes, which one would you prefer? Blood-based, tissue-based, urinary-based, or any others?
This is a very good question. In this moment, you have recently published a paper in European Urology Oncology about the role of urinary biomarkers in bladder cancer. And in this moment, there is no role to do in the diagnosis of bladder cancer. Perhaps in the next future we can do it, but in this moment I don't perform these tests in the diagnosis of bladder cancer. I do in the follow-up, in the surveillance of this patient, but in the diagnostics in this moment, no.
Yeah, I totally agree on that. In the diagnostic setting, I totally agree on that. In the diagnostic setting, I've spent 30 years of research on diagnostic markers. They don't really come up with anything, but in the follow-up, they're very valuable.
Perhaps in the next future we can do it, but in this moment it's not indicated.
Thank you for your answers. And indeed, in this case, we didn't perform any additional biomarker testing. We went directly to cystoscopy. And on cystoscopy, we found one papillary tumor, 3 centimeters, right lateral wall. And it appeared to be low risk, and cytology was negative. And I would like to ask next question to Professor Witjes. Do you use any additional imaging approaches, for example, MRI for virus scoring, or micro-ultrasound, or maybe others?
Well, since I've seen the tumor, I know that some centers, and that's probably a lot, use imaging for the initial diagnosis. I have seen the tumor, you've showed that, so I don't do anything to get more information about the bladder. We don't use MRI for that currently. What I always do is just to image the upper urinary tract, at least at the beginning of the diagnostic procedure. So in this case, I guess with a small tumor like that, and we have cytology, I'll probably do an ultrasound, not a CTU, but an ultrasound would be sufficient for me.
Yes, I agree with Dr. Witjes. I always do an ultrasound. And in my hospital, we usually do also an intravenous urography. The probability to find a tumor in the ureter or in the kidney is less than 50%, but I usually do an IVU.
I have a question for you guys. Would a positive cytology influence your behavior differently? Because we have noticed that many colleagues, after all, they do the cytology or they don't do the cytology before the transurethral resection of the bladder. Our colleague mentioned that the cytology was negative there. You would have a positive cytology. Would you ask for some exploration?
I would, I think, if I see this, I would say that it's a low-grade tumor, which doesn't fit with positive cytology. So, and then there might be, of course, accompanying CIS, but positive cytology would, for me, be a reason to do more things, for example, to do a CTU.
I think you should do a CT scan or a CT urography if you think this patient could have a muscle-invasive bladder cancer. If not, I think it's not essential.
Thank you. Yeah, in this case, we didn't perform any additional imaging, and we decided to go directly for transurethral resection of bladder tumor. And next question to Professor Martínez-Piñeiro. Would you use any enhanced optical techniques for TURBT? If yes, which? PDD-guided, NBI, others?
We don't use PDD. We don't use NBI. We have the short SPICE system, which gives a better image. But other than that, we don't use any other technique.
I work with Dr. Luis Martínez-Piñeiro in the same hospital, so my answer is, is the same.
Okay. And Fred?
Okay, but you guys do use some kind of additional imaging. I use blue light, which I've been working with for now 20 years. And it does give also in these tumors, you see some additional satellite tumors in around 20%. And those are the ones that then, apparently I have a recurrence at 3 months, but it's not a recurrence. That's something that you missed in the first TUR. So I think it's even valuable in lower risk and lower grade tumors to use blue light. I would prefer personally to have once blue light than a lot of installations. So I use blue light.
Fred, do you use blue light regardless of the size of the lesion, or only for bulky tumor, large tumor, when you feel that you are going to face a multifocal situation and you believe that the impact of the blue light will be positive on the assessment of a high-risk tumor, or any situation you would use it?
Well, maybe not any situation, because there's of course the cost aspect, although that's not too bad, but there are a lot of situations where I do use that, also lower grade to exclude multiplicity. Then if in this case cytology would be abnormal, for sure I would use more light to see whether it's CRS. If you have a larger tumor, even in invasive tumors, if you consider chemoradiation, then you want to exclude CIS. So I think there are a lot of decent and realistic indications to use blue light.
And just for the cost, you made a point there, and at least in France we had the experience of blue light being reimbursed and blue light being not reimbursed anymore. So outside of the clinical guidelines, there was a drop and a diminution in the use of the system. You mean that it is also an extra cost in the Netherlands?
Yeah, it's not reimbursed, but it's...
So who is paying? Your institution, the patient?
Yeah, our department is paying.
Okay.
And then as an academic center, we have some academic component, we call that. So it's not, we don't earn anything, but it doesn't cost a lot.
Okay.
And it's worthwhile for the patient, I guess.
One question. Do you have many false positive with PDD? Many cases where you have a blue spot that you think it's a cancer, you take a biopsy, it's negative?
Well, Louis, it depends a bit on when you do that. If you, for example, do that, you have CIS, you give BCG, and quite rapidly after BCG you use blue light, you will have more false positives, but you still also have more real positives. In the initial situation, the chance of having false positive is very small, and some people know that I'm colorblind, so I don't even see I don't see blue and pink. I say I see that, but I don't see that. But even for me, it's worthwhile. So, guys, that's just a tip.
Okay.
Thank you for this great discussion. And in our case, PDD-guided TURBT was performed. After that, patient received single-dose postoperative mitomycin C, and on pathology report, it was papillary tumor, urothelial carcinoma, TA, low grade, no lymphovascular invasion. Next question. Do you use biomarkers routinely in follow-up? It is kind of a repeating question, but for follow-up, and is it different for high-grade tumors and low-grade tumors? And also, what about variant histology?
Very good question. In this moment, in my public hospital, we don't have the possibility to use these biomarkers. Probably in the future it could be possible, but in this moment it's not possible. In my private practice, I have a very good experience with EpiCheck and with Euromonitor. In this moment, I only using in patients with low-grade tumor because I know there are some papers published, but you should have your own experience in the management of these urinary markers. My experience is very good. In some older patients, I recommend to do these urinary biomarkers, and when this is negative, I recommend not to do a cystoscopy. So my answer is yes, I think we should use.
I think Mario has a very good point there, that you have to get your own experience. That's, you start working with a marker. There are several on the market currently that are performing quite well, but you have to learn your own experience with that. And in my center it has become very popular, of course, since the COVID period. Patients were not not allowed to come or were reluctant to come. And we have a home-based test, so we send that home. The test is done, it's sent back to the laboratory, we get the result, we have a telephone consultation, and it actually works very, very well. Patients are happy, we are happy, our hospital board is happy because we don't see a lot of patients. So for me currently it's really something that I use in real practice. For me it's the EpiCheck, but again, more of those tests really perform very well in excluding high grade. And I use it in all patients, not only in low grade, in all.
Okay. Maybe just one point on that, because it's very important. Once again, we go to the cost, to the guidelines. As soon as it's not mentioned in the guidelines, you have your own protocol for the surveillance of this patient, and you will validate the data, or you use it in your clinical practice, I would say, out of your own experience, and you add the costs at the charge of the patient. One of the key issues is the meaningful of a positive biomarker, and the other point is whether or not it's going to be reimbursed to be incorporated into the practice. For these 2 points, how can we reach these 2 goals?
Well, I think the first thing is, of course, important. It's got to come in the guidelines. I check my own results, so I do it now alternating. I do a cystoscopy, a test cystoscopy. So I see in the negative tests whether the next time there is a large T3 tumor, which there isn't, fortunately. And I looked in my hospital at the cost effectiveness, and it is really cost effective, because you would be surprised what a cystoscopy is costing if you add the nurse, if you add the time of the doctor, the cystoscope, the room, cleaning everything. It's a lot of money, which we don't realize, but it's a lot of money. So the home-based test for my hospital is cost effective.
I think probably you have to tell the truth to the patient, no? You should speak with them, and you should tell if you have a negative result in this test with a probability of more than 90%, you don't have a bladder tumor. So this is very important. The most important topic with these urinary biomarkers is the negative predictive value.
I agree with you, where you are not afraid to miss a high-risk tumor in a patient who would be so-called suitable for active surveillance. You could use that to skip a number of useless cystoscopies. One other question is the choice of the test. You mentioned the nucleics. There are several markers on the market, companies coming, protein-based, DNA, methylation. Why is this choice? There is no head-to-head comparison. So how do you choose? Because obviously you choose the same, and you're not working in the same hospital, you two guys.
I have chosen DNA with EpiCheck and Euromonitor because I have participated in a clinical trial with EpiCheck some years ago. So this is my main reason.
So you had a learning curve with them, and you know how to use it.
Yeah.
Okay. And Fred, I think you work also for other companies.
I did studies with all 4 tests, the ADX, the CEPHID test, the nucleix test, and the Euromonitor. And we are currently, because that was the first one available in my hospital, also from a logistic point of view, we started with the nucleix. We're doing well. So I have no reason to change that, but there are more tests around. Yeah.
Can I expand the discussion to Alberto Bereda? Because I know that Juan Palo and Alberto in QuickVet, they have some other experience with the test. Do you share the feelings that we have just discussed, Alberto? Or can we have the microphone in the front row?
El micro del...
Okay. Yeah, we share the same feelings. I may add that why EpiCheck? The reason why EpiCheck is because we believe, or at least the literature believes, that DNA methylations are the best biomarkers we have. And I would remind that EpiCheck is 15 DNA methylations that they're looking at. All the rest of the tests, even the methylation tests, they're looking for 2 or 3 methylations. That's why the negative predictive value, and more than that, the sensitivity of this study, of this marker, is very high.
One additional advantage, I think, that you can use the nucleix test also
to go forward
yeah.
with the case, because we just have 5 minutes,
okay.
Right? It's very interesting. There is no head-to-head comparison, however, between tests, so we have to be very careful with the comparisons. All are the indirect comparisons. Please go on.
In our case, we decided to use additionally to cystoscopy urinary biomarker, one of the available on the market. So patient was followed with cystoscopy 3, 6, 12 months, no evidence of disease, cytology, urinary biomarker negative. But after 1 year of follow-up with cystoscopy, patient refused to undergo further cystoscopy procedures. He explained it why that it was quite painful, uncomfortable procedure. Question, which strategy do you choose in that? Would you try to convince patient to go to underwent cystoscopy, or you would consider using not invasive urinary biomarker alone, or with cytology, in combination with cytology?
I think the best option it could be urinary biomarkers together with cytology.
That's exactly what we did. And so at 12 months, urinary biomarker, cytology, both were negative. But then at 24th months, urinary biomarker appeared to be
Sorry, there is no slide. Yeah, okay, now it is.
Urinary biomarker appeared to be positive, and we went directly to cystoscopy. It was small papillary tumor, which appeared to be low risk. Taking into account age of the patient, which was already 84 years old, and some number of comorbidities, we decided to follow patients with active surveillance. So patient underwent cystoscopy. It was the same lesion every time, low risk, negative cytology, and this is final question, which would open final discussion. Which strategy now, and how often? UBT alone, or in combination with cystoscopy, cytology? What would you prefer in that case?
I think without any doubt this patient has a positive cytology. So in my opinion, I will do a transurethral resection of the bladder together with a randomized biopsy of the rest of the bladder. This is my opinion.
Well, as far as I understood, cytology was negative. Maybe I misunderstood.
Was negative? Sorry, I think was positive.
It was negative.
No, so you can do it cystoscopy together with cytology or urinary biomarkers. Sorry, yeah. I thought it was positive.
And
sorry.
If patient would be 60 years old, the same strategy?
Yeah.
Yeah, for me too.
I would try to convince the patient to undergo surgery, to do a transurethral resection in our setting with 1 centimeter tumor. It's just a very fast procedure, no problem. If he does not want to undergo a transurethral resection, then I would go and follow up the patient with either urinary biomarkers that we don't have because they are too expensive at the present time. You have to remember that EpiCheck is between 150 to 100 euros. There are other biomarkers that are cheaper, but you have to take a price, as Morgan said before, into account. So at the present time, clinical practice, 1 centimeter tumor and a recurrence with a previous TAG2, we would do transurethral resection.
Any comments from Professor Rouprêt?
No, we can move on.
So thank you.
Thank you very much. Thank you.
Thank you.
Thank you.